This video demonstrates the procedure for checking, clearing and maintaining the airway. First, position yourself over the casualty so you have a clear line of sight into the airway. Open the mouth by lowering the bottom jaw, being sure that the C-spine is not disturbed. Inspect the airway for any potential blockages or evidence of burns, ideally using a tongue depressor and a light source. Solid obstructions are removed using McGill forceps, reaching in only as far as you can see and maintaining the position of the head. Grasp the obstruction and remove. Once the obstruction has been removed, recheck the airway. To remove liquid obstructions, insert the suction easy, only as far as you can see inside the airway, and pump the bulb as shown to suction the liquid into the bag. Recheck and if required, repeat the process. Once the obstruction has been removed, recheck the airway. Should the mechanism of injury allow, or in a non-permissive environment, postural drainage can be used in an attempt to clear the airway. If the mechanism of injury does not suggest a C-spine injury, the airway can be maintained using the head tilt chin lift method. Tip the casualty's head backwards and guide the chin upwards. This will lift the casualty's tongue, therefore clearing the oropharynx, preventing blockage. If C-spine injury is a consideration, use the jaw thrust method. Place the ball of your thumbs over the casualty's cheeks and position your fingers under the angle of the jaw. Pull up on the jaw while applying gentle pressure against the cheeks. This will lift the tongue, clearing the oropharynx and preventing blockage. This method maintains the alignment of the C-spine. After either manual maneuver is carried out, breathing must be assessed. Airway adjuncts are used to prevent the tongue from obstructing the airway when a practitioner is unable to maintain manual maneuvers for any reason. The nasopharyngeal airway is sized by sex. On average, this will be a size 6 for adult female and a size 7 for an adult male. It should be lubricated thoroughly with an appropriate lubricant, or if one is unavailable, the casualty saliva can be used as a substitute. Inspect the nose using white light, looking for damage or any structural abnormalities that could be damaged during insertion. Insert the nasopharyngeal airway so that it follows the natural curvature of the airway, using gentle rotation to ease the adjunct into the correct position. Should any undue resistance be felt, do not force the nasopharyngeal airway. Instead, withdraw and try the other nostril. Once in place, assess for efficacy and check for breathing. The oropharyngeal airway is measured from the center of the mouth to the angle of the jaw. It is inserted into the mouth upside down, then rotated 180 degrees and guided into the airway. Once in place, assess for efficacy and check for breathing. An eye gel is selected based on the estimated weight of the casualty. Lubricate the back of the eye gel and insert the correct way up as far as you can into the back of the throat. The non-inflatable cuff will form a seal around the airway as it warms up with the casualty's own body heat. The eye gel will then be connected to a bag valve mask via a catheter mount, and assisted ventilation should commence. Check for rise and fall of the chest to confirm location.